or emails that you may have.
This is Suzanne. I'll just do a couple of quick housekeeping things.
Sure.
Everybody sees on their GoToWebinar the thing on the side, the toolbar on the side. You'll see a section that's called questions. If you have any questions during the presentation, feel free to type your question in there. If you have a question that you would prefer to answer out loud or ask out loud and have answered out loud, please use the raise the hand feature. If you raise your hand, then I will be able to unmute. Everyone at this point is in mute only, so you are in listen only, and I won't be able to hear you if you ask a question, but if you do raise your hand, I can unmute you and let Karen know that you have a question so she can answer it. So without further ado, thank you, Christine, for introducing Karen, and please take it away, Karen.
All right. Well, thank you, Christine, and thank you, Suzanne, for the opportunity to speak about brain injury. We are very passionate, and we believe at the Brain Injury Association of New York State that with increased awareness about what living with a brain injury is like, there will be increased understanding and overall improved quality of life for individuals, which I think anyone on the webinar today would say that's a good thing. So thank you for the opportunity to talk with you all. Thank you for those in the audience who have clicked on to listen to this. Today's presentation, it's hard because I can't have eye contact and see your facial expressions and body language, so bear with me when I say I want this to be a conversation more so than a lecture. I get really bored hearing my own voice drone on and on and on, so as they did indicate, please raise your hand or type your questions in as we go. I'm happy to stop in the middle of the slides if there's a question that's relevant to one of the topics, or if you don't understand me or some of the terminology. We tend to speak in acronyms. If you're missing an acronym or not sure what I'm talking about, please raise your hand, please type the question in. Okay, so we're going to start talking about brain injury. We're going to cover a little bit about what a brain injury is, mechanisms which brain injury can occur, and then we're really going to focus in on areas of deficit or challenge that a person with a brain injury may experience, because this is going to impact how they live their lives. Next slide, please. So to talk a little bit about statistics, every 13.1 seconds, someone in the United States sustains a brain injury. I think that's a pretty significant stat right there, every 13 seconds. According to the CDC, there were 2.5 million traumatic brain injuries in 2010. And 2.5 million is a huge number, but we believe the numbers of brain injury in the country are actually greater because that study only looked at reported emergency department visits, hospitalizations, and deaths that occurred. It did not include the acquired brain injuries, which we're going to talk about in a bit, and it did not include people who perhaps sustained a brain injury, a mild brain injury, and rather than go to the emergency room, maybe they went to see the primary care doctor, or if it was a child, maybe the parent took them to the pediatrician. So again, millions of people are experiencing this. It's called a silent epidemic because the numbers are staggering, and yet the awareness, the discussions, the conversations, and the activities in the communities don't really equate to the number of people that are impacted by this. More than 50,000 people die every year as a result of traumatic brain injury. That's about 138 per day. And it's estimated that 10 million Americans are affected by stroke and traumatic brain injury, which makes this the second most prevalent injury and disability in the United States. Again, significant, huge numbers. Next slide, please. And again, I apologize, this study was done in 2005 by the Brain Injury Association of America. If some of the numbers are a little fuzzy, but the big bar on the end there, the traumatic brain injuries that were reported, 1.4 million. And I like to use this as a visual aid because if you took the incidence of breast cancer, HIV/AIDS, spinal cord injuries, and MS, added them all up, it still would not be more than the traumatic brain injuries that year. So, again, I kind of am a broken record at times, so I apologize in advance for that, but this is a huge national epidemic. Next slide, please. So the numbers are huge. We're going to get into what brain injury is, but before we do, I want everyone to just take a second and think about this magnificent organ that is our brain. It controls everything we do, our breathing, walking, talking, thinking, our emotions, our behaviors, regulates our temperature, and it signals all the other parts of our body and tells them what to do. And yet, we don't really think about our brain or appreciate it until it's not working. Until the brain's injured, you really don't give much thought to all of the things that it coordinates every second of your life, right? A similar example would be we take for granted the ability to swallow without pain until we're affected by a sore throat or perhaps strep throat, right? Or the ability to talk and keep your voice. We don't think about it until it's not working or until it's very painful. So again, we don't think about our brain until it's not working, and then when the brain's injured, it's pretty much the focus of our life. It's the only thing you can think about is the challenges. Next slide, please. And if you want to get into neuroanatomy, I put this picture in here just for a little pop of color. Our brain has 4 lobes. We have the frontal lobe, the temporal and parietal lobes, and our occipital lobe. We have a motor cortex, which regulates movement, sensory cortex, and all of these different areas kind of have different responsibilities that they are in charge of, if you will. Next slide, please. And again, another diagram that kind of shows the area in the brain where these lobes are in our skull and what abilities come out of there. Our occipital lobe is our vision, parietal is sensory motor, temporal are languages, hearing, speech, and the frontal lobe is our emotions, our personality, our problem solving and reasoning abilities. Okay, and this is just very generalized terms. Go ahead, next slide. So now we've talked about the brain and all that it's responsible for. Now we're going to talk about brain injury. The most broadest definition is called acquired brain injury, or ABI, which is an injury to the brain. It occurs after birth. It's not hereditary, congenital, or degenerative. Okay, what does that mean? It means we're not born with it. We don't pass it along to our offspring like your hair color or eye color. Okay, it's not a disease. You don't catch it from someone. It's not a degenerative disorder. So there's a fully, typically developed brain. Something happens, there's an incident, and this results in a change in neuronal activity, which can affect the physical, metabolic, or functional activity of the cell. Right? Pretty basic. Something happens, the brain doesn't work like it used to. It's impaired, it's disabled. Okay? Next slide, please. Some of the causes of acquired brain injury are things like an aneurysm, tumors, stroke. We sometimes see brain injury after there's encephalitis or meningitis, when someone has an infection in the brain that causes increased swelling and pressure. Anoxia, or the lack of oxygen, can cause a brain injury. And when I used to think of anoxia, I would think of maybe if there was a near drowning situation and a person couldn't breathe, okay, that's anoxic or hypoxic, insufficient oxygen. But it could also be where an adult or any individual, actually any age, has a heart attack, and if the heart's not pumping the blood supply, doesn't carry oxygen to the brain, there can be an oxygen deprivation resulting in brain injury. So imagine that you survive a heart attack only to discover that you now have some cognitive challenges due to brain injury. Other examples of acquired brain injury are things like strangulation or airway obstruction, some other medical things, insulin shock, toxic exposure like carbon monoxide poisoning or neurotoxins, and then the subcategory is traumatic brain injury. Traumatic brain injury examples would be gunshot wound, concussive blast injuries, car accidents, whiplash, anything with trauma, and I'll get into more detail in a second with that one.
Karen,
Next slide. Yep.
would something like Korsakoff syndrome or alcohol-induced dementia, would that be considered a brain injury?
That's a good question. With the alcohol-induced, I'm not sure if that would be more of a degenerative, because it would be after prolonged alcohol or substance abuse, the brain tends to atrophy. So I'm not sure how they would classify those.
Okay.
And on the next slide, please, that's a great question that leads into the next slide. What brain injury is not? So it's not like Alzheimer's or dementia. It's not a progressive disorder, and I wonder if like the alcohol deterioration would be more a progressive. A brain injury is not a psychiatric disorder, but it's really tricky because it can present that way. A lot of folks with brain injury will have co-occurring mental health diagnoses, or sometimes are misdiagnosed and may present with bipolar symptoms or even be labeled schizophrenic, and it could actually be the brain injury that just was missed or not diagnosed. Acquired brain injury is not a congenital disorder, so it's not an intellectual disability or cerebral palsy. It's something happened, there was an incident, and then there's the injury. Any other questions on that before we skip ahead? Okay. Next slide. So I said we'd talk a bit more. You hear this term more in the news, especially, if you're watching the latest about the NFL. TBI seems to be the word that's out there more than ABI. Traumatic brain injury is a specific injury that's an insult to the brain that's caused by that external physical force or trauma. Okay, again, motor vehicle accidents, falls, if the head's hit, someone comes up behind you with a lead pipe or something, a bat hits you in the head. If it's penetrated with a gunshot wound or a knife, or the external physical force, for example, shaken baby syndrome or whiplash. So for the purposes of today, I'm not going to differentiate between TBI and ABI. For today, a brain injury is a brain injury. So just know that if you're reading medical records or you're working with someone or trying to place them in whatever the setting or search for services, these are some definitions and terms you may hear. Next slide, please.
So Karen, can I just ask a clarifying question? So when you have somebody who had, say, a stroke, that's an acquired brain injury, but for the purposes of applying for the TBI waiver.
Yep. It's still a brain injury, and the TBI waiver, there are some camps, if you will, that say we should do away with that and just call it brain injury or ABI waiver. The New York State Department of Health TBI waiver does accept and will take people with acquired injuries.
Okay.
And actually, I didn't include New York State's public health definition, but their definition of brain injury is actually TBI and or a medical incident and or anything else causing neurological damage.
Okay.
So, yeah, public health law calls it a TBI. So regardless of the type of brain injury, There's suspected, there should be anticipated that there will be some trouble with the person, their function in life, their ADLs, their thought process, and so forth. Next slide, please. Here are some other terms that you may hear describing brain injury. There are terms like focal damage. So focal damage would be if I were to fall headfirst and smash my forehead against a cement wall. You might see a skull fracture, a focal point of damage where I hit on the wall. Under that point, you may see contusions and bruisings in that particular area of impact. Then there's frontotemporal contusions and lacerations. This is where there's bruising and tearing of blood vessels back in the frontotemporal lobe. So, you know, the temples to the side of your eyes and before your ears, in that region where the soft gelatinous brain kind of moves around and may rub against the bony protrusions of the skull and tear and result in bleeding. Diffuse axonal injury is another thing in medical records. You may see it just DAI, and that is where the nerve cells are actually stretched so far that their axons, the main part of them, may tear or shear, or may get stretched so far that they don't bounce back in a way in which they can conduct the communications from nerve cell to nerve cell. It's hard to do this because you can't see me, but I'm trying to use my hands to show it stretching. So imagine if you were holding a rubber band and you'd stretch and stretch and stretch. If that were your axon of a brain cell, you know, over time the elasticity of that may diminish. Or, I know I've done it before, if you stretch the rubber band too far, they snap, in which case they can't conduct the messages that we need to get through the brain. And that is a problem.
What kind of an accident usually results in that with the diffuse axonal injury?
Diffuse axonal, we see this a lot in car accidents where there's a big acceleration, deceleration, you know, very fast, and then it stops. So if a car hit a tree and the brain is propelled forward and then suddenly stops and it bounces back, where there's a lot of speed involved, or even flipping off the handlebars of a bicycle and so forth.
Okay.
Regardless of the mechanism at which an injury occurs, there's still going to be, you know, the residual challenge. Next slide, please. So the focal, frontotemporal, and diffuse axonal talk about the primary injury. So again, back to my fall example, if I fell and smashed my head against that cement wall, that was my primary injury or the incident. Sometime after this, some of the following things may occur. We may see hematoma or blood vessel damage, swelling, increased intracranial pressure, infection, and in some situations, seizures. So when we think someone has fallen or when we suspect someone has had an injury, especially if we're dealing with elderly populations, you really want to be careful and monitor people or get them checked out. It's a human nature to kind of, especially in a situation where it's a fall or an embarrassing situation, initially people may refuse medical treatment or not want to draw attention to this, but it's this secondary damage, the swelling, the increased intracranial pressure that can result in sometimes serious medical situations, can lead to coma or death if not treated. So the takeaway is, when in doubt, get everybody checked out, okay? So we talked about mechanism of brain injury, and now we're going to go through these 5 broad categories, if you will, of the most commonly reported challenges people face after a brain injury. We're going to start with the physical. Next slide, please. Okay, and again, This list is the most commonly reported. Not every person with a brain injury will have these. Some people will have a few, some people will have a lot, and there's any number of combinations. It's important to remember that each person is an individual with a unique makeup, genetic makeup, their medical history, and so forth. Each injury is unique, and everybody's rehabilitation, recovery, and residual challenges is going to be very person-specific. So we talk a lot in this field about person-centered planning. We want to be very careful that not everybody with a brain injury fits into that same mold, okay? So physical challenges people may experience is the loss of smell or taste. When I first learned this, I thought, how terrible. If you love to eat like I do, or you love to smell fresh cut grass or flowers or bread baking, whatever it may be, that's a huge quality of life thing. Then we think about the medical implications. You know, it may affect their weight. Someone without smell or taste may not want to eat. They may not have an appetite. They may be underweight. Can go the reverse. Someone without smell or taste may get that gratification from texture and may overeat because they are sampling different textures on their tongue. There's also the not so much quality of life, but safety issues related to this, such as if I can't smell fire in my apartment, or if I can't taste that the milk is sour, or that the food has spoiled, that's a safety and a health concern there. So it's important to know if this is an issue for people. Hearing difficulties can present in a variety of ways. We can have sensitivity to sound, which I find as I age, I don't like those noisy settings as much anymore. But with brain injury, people can be really irritated, really distracted, really uncomfortable in settings where there's a lot of noise going on. Think about a diner. You know, there's coffee cups and silverware and all these things clanking around, and people talking over people talking. So those types of settings can be very aggravating for people. They can also have a ringing in the ears or tinnitus. And again, it's challenging to focus in your day and to do what's being asked of you if you have sensitivity or tinnitus. Visual difficulties, again, can present in a variety of ways. There can be vision loss, okay? We could have double vision, blurred vision. There could be a visual field neglect, meaning that if I had a left visual field neglect, if you set something directly in front of me, I might only see something from midline to the right. I might not see from the middle of my nose to the left. And these types of things are important. Again, if I can't see all the tools that you place in front of me, I can't do the job. Or if you set my medication in a spot where I can't see it, I may not take it because I didn't realize it was there. The other safety concern is if it's a visual or a depth perception issue, I might be at more risk for falls. So it's important to pay attention to vision. Vision is a tricky one because people don't always report that they have these issues. So I would say get people's eyes checked, and not just by a typical eye doctor. People can have 20/20 vision and see very well, but still have these other neurological challenges. So you might consult with someone like a behavioral optometrist, right? Other physical challenges commonly reported are balance difficulties, speech difficulties. Sometimes it's the physical ability to form words and get them out. Then there are also difficulties with speech related to the cognitive, where I'm not really sure what I want to say. And so that's why I'm not responding to you, because I'm not sure what you're asking. So that could be part cognition, but sometimes it's physical. I can't form the speech, or if I form it, it may sound like I'm intoxicated. I may slur my speech. Motor control and coordination are other physical problems that we see. Fatigue is something that you can't see, really, but it's very real for someone with a brain injury. Fatigue after brain injury is different than how you or I may fatigue. In my typical day, not to bore you with my life, but as an example, when I wake up after that first or sometimes second cup of coffee, my engine's revved up, I'm full of energy and ready to tackle the day. I go to work, I work through the morning, might take a quick little break, maybe some meetings, some phone calls here, there. After work, may go to some errands, may grab dinner, sometimes squeeze in some fun social recreation time, and by the end of the day, by the time I climb back into bed, throughout the day my energy level has gone down and down and down until I'm like, hey, I've done a lot today, I'm ready for a break, back to bed, recharge my battery, so to speak, and then the next day get up and do it all again. I don't know if most of you would agree with that, but that's our energy and how fatigue kind of comes on gradually with exertion for most of us. Fatigue with brain injury can be very sudden, and it can be very immobilizing. Fatigue can be sometimes physical, but more often than not, it's this cognitive fatigue or mental drain. We're going through a typical routine or trying to do the simplest of tasks takes so much more energy for the injured brain, takes so much more focus and so much more attention and everything that someone with a brain injury, their energy levels can drop off very quickly. I mentioned how I get up and I have my coffee. Someone with a brain injury may get up and may not have that quicker arousal or ability to get their engine running. And then just going through the morning routine of making the coffee or getting dressed or going through the shower routine, thinking of what do I wear, where do I have to be, all of these things can exhaust them. And not just starting the day. This can hit at any point in the day, especially when there are increased cognitive demands put on someone. So as we work with people with brain injury, we'll want to tune into how are they looking? Are they really with you, or can you see in their eyes that maybe they're fading away a little bit? Their twinkle's gone out of the eye, they're drooping a little bit, you can see that they're really not keeping up with what's going on, and just tune into that, because we can prevent this from getting to the point where someone wants to crawl into bed and take a nap. If we take frequent breaks, and we'll get to this in the strategies part, but you know, there's ways to prevent this, because once you're fatigued, it's hard to bounce back from that. So a lot of these things I'm talking about, we want to think about in the community setting for the folks that we're assisting. How do we prevent this from being a problem? Okay. Other physical things, seizures, are common in about 1/3 of people with brain injury. And sometimes this is just right after the injury, there may be some seizure activity, or some people can develop seizures that stay with them. Decreased tolerance for drugs and alcohol are common. People don't metabolize even prescription medications the same way that they used to before injury. Headaches are the most common physical thing that is reported after brain injury. And again, not your typical headache where you pop a couple aspirin or Advil or whatever your drug of choice is, and it's remedied. Headache that stays with you, headache that doesn't fade, headache that can be there for months and sometimes years. And then finally, sleep disturbances. So imagine, we've just talked about the physical things. If you had even 1 or 2 of these challenges, what life is going to be like. And I want you to think about that, because when we work with individuals with brain injury, we want to come from a point of empathy and really try to imagine what this is like. All right, so that's physical. Let's talk a bit about cognition. Cognition is our thought process. Again, most common reported problems after brain injury, short-term and working memory. Probably one of the biggest challenges, because if I can't remember what you asked me to do, we're not going to get very far. If I don't know or remember what time am I supposed to show up, I may be late for appointments or I may miss them altogether. If I can't remember if I took my medications, that could be a big problem, right? Some people think they took things and didn't. So missing a dose has a negative impact. Some people forgot that they took them, so they may take medication again and then double dose. That's a problem as well. So again, memory makes all aspects of life challenging. Other cognitive challenges are our ability to pay attention and stay on task, concentration. Some folks have distractibility issues, easily distracted. And again, our uninjured brains are able to tune out all the stuff that's not relevant to the moment and focus. Great example right now, I'm in my office and I'm trying to focus on my presentation, and in another office space I hear voices and doors, and they must be having a meeting in the next office space. But I've been tuning that out and focusing here. Someone with a brain injury might be distracted. What's going on over there? What's that other noise? Should I pay attention to that? Which they get distracted, they lose their attention and concentration, and so whatever's happening in that moment is not going to be relevant, is not going to be paid attention to. Okay? More cognitive issues can be decreased verbal fluency, decreased comprehension. I may not understand what you're saying. You may use all the right words and think I should know this, but I may not understand it. The word choice you're using is foreign to me. And sometimes it's things that we, again, take for granted. I was working with a person who, suffered from chronic headaches, and he had problems getting through his day program, and what we decided to do was to monitor him for headaches. How frequent is this happening? Does the neurologist need to change medications, or what's going on here? So the plan was to ask him, do you have a headache? Do you have a headache? Simple. We all know what that means, and yet for this young man, every day he would say no. Nope. Do you have a headache? No. Yet we could see the squinty eyes and the rubbing of his forehead, and sometimes head would go down on the table. And so finally one day someone said, are you in pain? And he says, yes. Where are you in pain? And he points to his head. And again, I would think everyone would know what headache is, but for some reason that word didn't register with him. That's a great example of how things that we assume sometimes is not what's really happening. Okay? Other cognitive issues, information processing speed or slowed reaction time. I don't know about any of the listeners in the audience today, but if you ask me a question, I would like the opportunity to form my response and respond to you. Okay? That's how our conversations work. That's how society is. So for people with a delay in reaction time or information processing speed, keep in mind that when you ask questions, some folks might take a little bit more time to understand your question. That, hey, give me a minute here while I think about what you're saying. Or they may need extra time to get the response out, to think about what's that word I'm looking for, what's my answer, how do I react. It's very discouraging for people if you ask a question and you don't allow them to answer. They get discouraged, and then they may not want to participate or even try. So be aware or try and investigate. Are they not responsive because it's a processing speed issue? Other cognitive challenges, system arousal. Are they alert? Are they able to get that engine revving, so to speak? Problem-solving ability can sometimes be diminished. Changed intellectual functioning is a possibility. And difficulty with abstract thoughts or concepts. Thank you. Executive function is our next area we're going to talk about. And again, executive function is something we all do every day. We are a society of multitaskers. There's some debate that that's not good, but I think that's another webinar series. So executive functioning is, what goal are we setting? What plan are we going to make? What do I need for this plan? How do I get started? How do I initiate the plan? If the plan's not working, do I have the ability to modify it? If I can complete the plan, did I do it in a timely fashion, or did I meet the deadline? So all of these things, people with brain injury can get stuck in any one of these areas or can have trouble with all of the above. Some folks, and again, not everybody, if you ask a very broad, open-ended question, such as, you know, if there's an individual in the community and part of his goal in his waiver or in his program is to do recreational activities, and I say to this man, what do you want to do today? That's a pretty open-ended question, right? And for this particular person I'm thinking of, it was very overwhelming. I don't know, you know. So his answer would be nothing. Don't want to do anything. So upon further investigation, it wasn't that he didn't want to participate, that he didn't want this recreational activities. He didn't know what his options were. He didn't know what was available or what was within his means. So rather than, what do you want to do today, you know, we gave him specific ideas. Do you want to research or go to a movie? Should we go out, you know, should it be like a food or a beverage thing? Do you want to go get something to eat? We could do dinner or lunch. Do you want to go to the bookstore? Do you want to find something to read? Or do you feel like taking a walk in the park, you know, indoor, or it could be simple as, do you want indoor activities or outdoor activities? He wasn't sure how to set his goal, okay? If we carry on with this example, you know what, someone might not know, okay, well, if I choose to go to the movies, what do I need to initiate that? What do I need to start that plan and process? You know, you need money to go to the movies. You need to know what time, and you need to know how are you getting there, right? Those types of things that people may get stuck with. Not just with recreation, but with doctor's appointments, with following up on phone calls, with putting things in the mail. You know, if your executive functioning is impaired, it may be challenging to manage your household without some supervision or oversight, okay? This is pretty important. If I don't pay my electric bill, I'm not going to have power, right? So again, it's important to know what are people capable of and where do they need assistance. Next slide, please. Another area we're going to talk about today is the affective behavioral. Okay, so folks with brain injury can sometimes be impulsive, especially when the frontal lobe is impacted. The ability to regulate our emotions. The term emotional lability means 1 minute or 1 hour or one point in my day I'm kind of even-keeled and happy and calm, and then I can be set off, I can be upset, I can be crying, I'm very emotional. It's the roller coaster of emotion. I'm up and I'm down, and I just can't really even out. People with brain injury can have increased irritability. I want to make you think about the previous section where we talked about all the physical problems, the pain, the sensitivity to light. When I talked about vision, I talked about, you know, blurred vision, double vision, no vision. I forgot to mention sensitivity to light. So someone with a brain injury may have the physical challenge of, hey, if I'm sitting under a fluorescent light or I'm out by that sunny window, when the sun does happen to shine in New York, that can irritate my system and be painful. So if I have a brain injury and I have these physical things going on, it's pretty easy to see why I might be irritated. I might also have increased frustration and decreased frustration tolerance. So I can't put up with stuff like I used to. My fuse is shorter. I'm liable to get very frustrated and aggravated, and people aren't allowing me to answer my questions. They're talking over me. I'm not following the conversation because of my attention and my concentration problems. And so sometimes people blow up. They're impulsive. They may say and do things that the rest of us might know are inappropriate. Sometimes the ability to filter what I want to say could be impaired, or the ability to bite my tongue. Everybody's heard of that phrase. You know that if you say that, you're going to get yourself in some hot water. So all these things can be part of the brain injury. All of these things can be something that people struggle with. Other affective behavioral challenges are tension and anxiety, as well as depression. It's not a stretch of the imagination to imagine why someone might struggle with depression after this life-changing incident. Aggressive behaviors can sometimes pop up as the result of brain injury. Disinhibition, and I've touched on this, you know, I just say what's on my mind without thinking about the consequence, or I may do something or act out without thinking about what happens next as the result of my action. It's common to see changes in sex drive as well as changes in personality. Personality changes more often than not. People become more reclusive. They lean towards more solitary activities, and again, partly due to it's easier that way. I don't have to keep up with the conversation. I don't have to be exposed to these environmental stimuli. I don't want to go to that party because there's just going to be too much going on and I won't have fun, and I might blurt out and curse at someone. So these are things to keep in mind, that maybe it's not that the person is just rude or vulgar. Maybe it's the brain injury and they can't control it. Next slide, please. Okay, the final category we're going to talk about before we get into further challenges and working with the injury is psychosocial. So after a brain injury, it's common that people's educational and vocational goals may not be fully met, or they can't go back to. If someone who's a high school student, regents track type of student, has a severe brain injury, they may not be able to meet the requirements to carry out the regents degree. They may not be able to take a full course load or do the entrance exams to college. If someone is working and employed and has a brain injury, they may have vocational challenges based on however the injury presents. Okay, so if I'm a person who sustained a brain injury, and due to my fatigue, due to my headaches, I can't handle working 8 hours a day, I may not be able to work full-time. I may need to ask for accommodations. I may need a shortened work day, or instead of full-time, go to part-time. Or if I have a very specific job, if I am an orthopedic surgeon, but I have memory problems and balance difficulties and so forth, I may not be able to go back to that operating room. Okay? After brain injury, there's a variety of family issues that may occur. if a family was dysfunctional, if you will, before the brain injury, before the accident, chances are things won't be drastically improved after the injury. So it's important to know, as you work with individuals, what's the family dynamic, what was the family makeup pre-injury. And again, this injury, this disability is different than some of the others because people weren't born this way. So the intrapersonal difficulties someone experiences, that loss of self-esteem, depression, frustration, that shaken sense of self comes from knowing I could do all these things before and now I can't. I could work and support the family and now I can't. Or maybe I can't do it the same way. There's very much this awareness for the person with the brain injury, the survivor, as well as their family members, that he or she is not the same. And that's a really hard thing that families struggle with. A lot of times too, especially if there's multiple people living in the home, everybody has their role, everybody has their job, so to speak. Who pays the bills, who gets the groceries, who drives the kids to soccer practice. After a brain injury, that may shift around a bit, and that's not always an easy shift. So just know that as people are adjusting to this new normal or this new life, that the whole family is really struggling, and as much as we support survivors, you need to take into account the family dynamics. Next slide, please. Further challenges after a brain injury are community resources. I'm guessing we have people that are listening in from a variety of places in New York State. Where you live and your community can make a big difference in your rehab plan and your recovery. I am speaking to you from Albany, New York. We have a lot of programs. We have rehab facilities, a lot of waiver providers, a lot of neuropsychologists. We have public transportation. There's a lot going on here. If I live way up in the North Country or out in the middle of the Adirondacks, my community resources may be different than in a metropolitan area. I may have limited access to transportation. I may have not as many agencies or staff to choose from. I may be more isolated and not have the opportunity to, say, walk a mall or take the bus to go to a diner. So community resources are a huge challenge based on where you live. The environment of care as well. Who do I live with? Where am I going? If I'm coming out of the hospital or out of a nursing home, who's going to be there to help me with this? And are they there by choice, or are they there because they're required to be? That makes a big impact on the outcome. Adaptive equipment. A lot of folks may need, adaptive equipment in the home, or, to walk, or devices. There's a lot of stuff out there, but again, who's going to pay for it? What type of insurance? How do we access this equipment? How do we put the environmental modifications into place? Other informal supports can be a challenge. So usually we think of the family as the primary informal support, but what else is in the community? Is there a faith-based group that maybe the person was involved with that could help out? Is there a civic group or a club, or was this person a member of, the American Legion, the VFW? Who else is out there that can help support the individual in the community? People with brain injury can be vulnerable to abuse and neglect. And this is something as professionals we need to have on our radar screen, especially going back to the cognitive. If I have a memory problem, I might not be able to be the best reporter of what's happening. Obviously, there are some clear signs of abuse if it's a physical abuse. But when we get into neglect or people being exploited financially, that's a more difficult thing to spot. So be aware that, you know, if I have a cognitive deficit and you want to come visit me, I may say it's okay if you want to take money out of my drawer or my bag because you're nice to me. Yeah, you want to borrow my car, I may agree to that and not really remember that I gave you the keys and let you take off with it. So be aware people are vulnerable. So again, we need to be mindful and watchful to protect them. Other challenges, socialization. Okay, if I can no longer drive, I can't get out to the book club. If I have some visual difficulties and some hearing sensitivity to sound, I may choose not to socialize. But we have to be careful that people aren't isolated, because with increased isolation comes increased depression. Okay. Other challenges is the medication management and compliance, and I talked about this a bit, so I won't go over it too much. Do people know the dose? Do they know how to renew their prescription? Do they remember when to take it? General safety concerns again. Can they smell gas? Do they know the exit plan? Do they know who to call in an emergency? Do they know if you suspect there's a gas leak, do you know you need to leave the house, get out, call from a neighbor's house? Other challenges are dietary compliance. And we might see this, you know, maybe they're supposed to watch their calories, maybe they have high blood pressure and are supposed to limit salt, but forget that they're supposed to monitor for salt, those types of things. Or sugars and sweets with diabetes, because especially with the elderly population, sometimes it's not just brain injury we're dealing with, there are other medical challenges to further complicate the situation. Next slide, please. All right, so when we work with someone with a brain injury, we don't want to underestimate them. There are still many strengths and abilities to utilize, although looking at the clock, I've talked for almost an hour now, and the bulk of our talk has been about disability and deficits. Don't underestimate, there's still many strengths and abilities to use. Don't be misled by what looks like a personality trait or a willful decision. Okay, meaning if you come into someone's home or in whatever setting and you're working with someone and you ask them to do something, to do a specific task, and they don't do it, we're not going to assume that they just are non-compliant. We're not going to label them as difficult. We are not going to say, oh, they're just not trying hard enough. Rather, we're going to be detectives. We're going to investigate and ask ourselves, why aren't they completing the task? Okay? If I say to someone I'm working with, okay, Karen, it's time to make lunch. Let's go make lunch. And Karen sits at the kitchen table, doesn't move, and is looking out the window at the bird feeder. You know, we're not going to say, oh, Karen's just, she's ignoring me, or she doesn't want to participate. Rather, you're going to stop and think about, again, hearing, did she hear me? Attention and concentration. Was she paying attention to me when I was speaking? Was she looking at the birds or was she looking at me? I don't know. So was it willful decision or did she not understand what I said? These are the things we want to think about when we work with people with brain injury. Okay, next slide, please. So it's very important to understand the people you work with, so you know what they're capable of doing for themselves and what they need help with. So what type and level of support do they need? We're not going to underestimate. We won't overestimate either. Okay? So we want to know, does Karen need just verbal prompts? Or does she need a little hand-over-hand assistance? Or does Karen need pretty much standby or 100% support? these are the things you're going to want to know so that you're not doing too much. We don't want to encourage people to be dependent. We want to encourage independence, but we need to know what we're working with. Next slide, please. So when we work with people, this is a little acronym that people created a while back, and the phrase would say, if you follow the road, you won't go wrong. I don't know. So ROAD, the acronym ROAD, is how we're going to help support people with brain injury. We're going to read and review everything we can. If you have medical records, history, I don't know, any types of summaries. As we work with individuals, we want to do our homework, so to speak. We want to read up on them. We want to observe. We want to watch the person in their setting or in the home setting or wherever, and just try and take in some of these little physical cues that we might see. Are they squinting? You know, are they sitting up and alert, or do they seem a little fatigued? Do they look balanced? Do they look like they're engaged? Are they paying attention? So observe. See what you can deduct based on just observation. We're going to ask questions. You know, ask questions to whatever setting they're coming from. If they're in the nursing home, maybe there's a team leader who can share what this person is about or what they've learned about the person. If possible, ask questions of the family members who've probably known them the longest, you know, about preferences or what have you observed or what should I know. And most importantly, ask questions of the individual with the brain injury. And this is the step that sometimes professionals skip because we think we have a job to do and we're trying to help this person and everything. So take the time to ask the questions. What do you want? How can I help you? You know, what do I need to know about you? Because they're living this, and they may give a perspective that none of us have thought of. And finally, don't assume. Back in the olden days, they'd say, don't assume, because if you break that word up, you make an ass of you and me, right? Again, we're not going to jump to conclusions. We're going to investigate the situation and figure out what's going on. Next slide, please. One of the things you can read, which is a great tool if you can get your hands on one, after brain injury, is a neuropsychological evaluation. This is a helpful cognitive test that helps determine what strategies will be useful to the person. It shows how the person learns best, and it translates into the daily experience of the person. It will help us determine the things we can't see. It might explain if it is a concentration issue versus a memory issue, or is it processing speed? And so neuropsych eval, again, is a great tool if you can get one done, and there's a lot of percentages and jargon in the beginning part as well as history. Usually a good neuropsych in the back will give very specific strategies about how this person can live best or what types of supports they will need. So highly recommend them. And another thing that I maybe neglected to say in the beginning, people with a brain injury oftentimes are diagnosed when it's pretty severe and there's coma or loss of consciousness or open head wounds and so forth. Not all brain injuries will show up on imaging, meaning someone could go into the hospital and have a CAT scan or an MRI, and the results will come out normal. The neuropsych eval, the cognitive testing, will show the cognition, the thought process deficits that imaging won't. So again, tuck it away in the back of your mind that just because the MRI was fine does not mean that there couldn't still be brain injury there. Okay? Next slide, please. Thanks. So strategies, no matter what setting you're working in or what your role is in this person's life, whether you're a professional or a home and community support staff, or you're just trying to share information with the people that are going to be working with this individual. It's always helpful if we can monitor for fatigue and pain. Okay? Remember that fatigue and the headache, and a lot of times there can be chronic other physical pain. So monitor for this. Because if I'm in pain, I'm not going to really want to do my physical therapy. If I'm fatigued, I'm not going to want to fill out my menu for the day or work on my shopping list or do anything. And we can't take a pill to get rid of fatigue, so we want to prevent it by allowing rest breaks in the day. Instead of constantly going, maybe the schedule is broken up where you do a little bit and then you take a little break and then you do a little bit and you do something fun or relaxing and then you do a little bit, okay? Rest breaks in the day or as needed. Present information in a slow format. Break big projects into manageable pieces, or chunk information instead of coming in the door and sitting down with someone and, you know, rattling off everything you've got to do in your shift. Maybe we're going to start with, okay, I'm here, and in the next little bit, this is step 1. Step 2. Instead of giving them the 12 or 15 steps or tasks that you need to do, maybe it's one thing at a time, and then another thing, and another thing. Use a multi-sensory approach. This helps for someone who, if you're not sure if they are a visual person, like they do better with pictures or written lists, or are they an auditory person? Do they do better if you tell them and give them verbal prompts? Maybe you do both. Maybe there's pictures, maybe there's something to cue them. Multi-sensory approach, something you can show them to demonstrate what you need to get done. Extra time to process and form response. I think we've covered that pretty well today. You want to repeat and assess comprehension. And I repeated that. Repeat, assess, repeat, assess. It's fairly common with people with brain injury to try to bluff. And by that I mean, if I am not understanding someone and they're asking me questions or they're making a request of me, I may smile and nod and say, okay. And someone might believe, okay, Karen knows what I just asked her to do. Someone with a brain injury may bluff in the sense of, I don't want to admit I don't know, or I don't want to stand out or look dumb. So when you ask someone to do something or you're telling them something that's very important, don't just accept the smile and the nod. Ask them, okay, so Karen, we're going to go to the doctor's at 3 o'clock today. You need to be ready by 2:45. And Karen may nod and smile. Then you might ask, okay, so we're going to the doctor, and what time do we need to be ready? Those types of things. Have people echo back to you or repeat what was said so you know that they really are with you. Other strategies would be to use things called scripts. Not a script like a pharmacist or a doctor would use. A script is like something someone says to themselves or reads or reviews, or something a staff would say to the person to help prompt them through a process. If someone has impulse control issues or gets flustered when they're supposed to perform, a certain task, the stop, think, do script might be helpful. I get upset. When I get upset, I can't think. When I can't think, nothing happens. So someone might help me say stop and have a picture of a stop sign or hold up their hand like stop. Think about this, and maybe a picture of someone pointing to their head like thinking, and then do. And just these little scripts can sometimes be used to help people Just take that little pause, hit the pause button, think about it, and then execute or do what they're supposed to do. Increase supervision without increasing dependency, right? We want to essentially work ourselves out of a job. We want the person with the brain injury to do the most that they can, because being independent is a valid goal of all of us, right? So if you think that I need assistance with my meals, that's great, but you want to determine how much supervision or assistance do I need? Because if you want to put my plate in front of me and cut it all up for me and pour my milk, that's great. And I might just let you do that because it'd be easier for me than trying to cut my own meat or pour my own milk. But we want to increase independence and decrease the supervision, decrease dependency, if that makes any sense. Communication with someone with brain injury should be clear and concise. Again, we talked about people can be very literal, so we want to avoid slang phrases, we want to avoid inferences and sarcasm, be pretty clear and concrete. Next slide. Other strategies for attention and concentration, specifically, reduce distractions in the person's work area, so they're just focusing on whatever the focus needs to be on. Divide the work into smaller sections. Pay attention to lights and sounds that may act as a central nervous system irritant, because as their system gets irritated through the lighting, through the temperature, through the noise, this is going to increase fatigue. When fatigue goes up, this may increase behaviors, and when behaviors are happening, there's a decreased learning capacity or decreased ability to get anything done, right? So again, pay attention to the environment to minimize irritating the system. Preferential seating for folks is sometimes helpful if it's in a group setting, or if they're in program, you know, preferential seating may be near the speaker where they pay attention, or preferential seating may be away from the person that annoys them. It may be with their back to the window so the sun isn't glaring in their face, or it may be near the door so that if they need to take a break and walk in the hallway, they can do that. Visually clean, low stimulus environment. Brain injury friendly environment is very decluttered, very simple. Trying to think of a setting to describe this, because without us being in the room together, you can't see how messy my room is. But if we were in a conference room, a visually clean, brain injury friendly environment would have all of the chairs pushed in, all of the things lined up. If there were materials on the table, they would be neatly stacked in piles. It's less visual scanning, it's less distraction, and it's less energy spent on assessing what's going on in the environment and more energy spent on this is what I'm supposed to focus on. Some strategies for memory, again, frequently repeat and summarize information. Teach the person to use sticky notes, Post-its, calendars. There are these great things called smartphones, and regardless of your age, there are some wonderful apps for smartphones. So, you know, use the technology, the assistive technology that's out there. Other considerations, be encouraging. You are. I don't know any of you personally, but if I had to guess, I would say nobody got into the human services field to be rich. You probably chose this because you're a caring, compassionate person. So be encouraging. Focus on strengths, yours and theirs. We want to acknowledge their struggle. We don't want to poo-poo what they're going through because it's some pretty serious stuff. Use humor when appropriate. Use a non-confrontational approach, okay? And if someone's agitated, we want to allow them to have time to decompress or calm down. We don't want to be so headstrong and determined to win this argument or be right or teach them in the moment. We want them to calm down and then maybe after the fact review what went right, what went wrong, and what can we do in the future to prevent agitation or behaviors or whatever the negative was. Offer choices and empower the person. Use a person-centered approach. We talked about that. Remember, you work for the individual, so they're the driving force here. Be honest, but gentle and tactful. That's got to be practiced a bit, but you want to be honest with people. Hey, when you call me these names, I don't want to stay in the room and listen to this. You know, I want to help you, but you can't call me that name, maybe. And on the same note, when people are called names or say something or do something that's offensive to us staff, don't take it personally. A lot of times it's that frontal lobe, that impulse control, that it's out of my mouth before I thought about that it would hurt your feelings. So don't take it personally. Just remember, it may be the brain injury speaking. No matter if it's someone with a brain injury or I don't care what, we're going to treat everyone with dignity and respect, right? Don't talk down to the person. Allow for grief. As we said before, there's this pre-post injury recognition going on, so we want to allow them to grieve for that former self. We want to avoid arguments or blame. Respect your differences. It's also very important to understand someone's cultural and personal values, because this is about their culture, how they live their house, in their house, what their values are. Progress may be slow, but keep at it, because this is important, okay? Next slide, please. Other considerations, especially like with folks on waivers and in the community-based settings, other considerations are privacy. This is their home. They're allowed to do what they want to do, and they have rights to conduct themselves in a certain way because it's their home, right? So we want to offer privacy, dignity, respect. Dignity of risk talks about is the concept that even if you have a brain injury, you still have the right to try. Even if I don't think you can achieve what you want to try, go for it, you know? And an example of that would be someone who was on the waiver and said, you know what, I can't drive the car anymore, but I want to take the bus and go to the mall. I'd like to go shop. I'd like to get out once in a while by myself. The family freaked out and said, oh my gosh, what are we going to do? He can't ride the bus. He might get lost. He might get hurt. Someone might try to take his wallet. Nope, 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 right? Wrong. Dignity of risk said, let's figure out a way to try. And so we're also going to think about putting the proper supports in place. We're not going to buy him a bus ticket and say, okay, good luck. You know, in this example, there was some travel training involved and some shadowing so that someone went through the bus route, rode the bus with him, eventually backed off a little until he demonstrated, hey, he can do this. You know, imagine how that felt for him to achieve that goal. On the flip side, imagine what that would be like if everything you wanted to do, someone said, no, you can't. So can versus can't whenever possible. You know, maybe if my goal is to go back to work, maybe I can't be a surgeon, but maybe I can volunteer in the hospital and be in a similar setting. We want to try, can versus can't. And again, this leads to the right to fail. I don't know about anybody else on the webinar, but I've made a couple poor decisions in my lifetime, and it was a failure. But I learned from that. And all of us have the right to try and the right to fall on our face, figuratively. You know, we have the right to fail, and so do people with brain injury. Because if it doesn't work, hey, they tried, maybe you learn from it, you modify the plan, come up with something else, try again. All right? As staff people, I think it's important to emphasize we want to take care of yourself. Seek supervision and support from your supervisors and peers. This is hard. Working in this field is very challenging. It's very rewarding. You know, it gives you that great feeling of a job well done. You really made a difference in someone's life. However, it's stressful. So again, lean on your peers, talk to your supervisor, take care of yourself, so that you can continue to do the great work that you do. And give yourself a pat on the back for a job well done. Because if not for all of you trying to do the best for these folks, I don't know what their outcomes would be. Okay? Next slide, please. Okay. Structure the person's day. Use a schedule to help. Again, in the beginning of this talk, I talked a bit about how we take things for granted. You know, when I wake up in the day, I have a general sense of what time I need to be at work. The big meetings or today's presentation, yep, I know I got something major going on today. After brain injury, it may not be that readily available to someone in their recall, so offer them structure, give them a schedule. You know, maybe there's a schedule in the kitchen or a menu or some checklists. You know, give them something to help structure or schedule them. Allow for presets in the schedule, meaning, you know, in 5 minutes we have to go to lunch. Give them a little warning. Or maybe if they need more time to get ready, if you're going to a doctor's appointment or have a meeting, maybe it's, okay, in 20 minutes this is going to happen. So there's no surprise. So people can anticipate what's coming and so they can prepare. As we do this, we want to offer choices. Not just with presets and a schedule, but offer choice whenever and wherever possible, because choice empowers people. Choice gives them control. If I've had a car accident and a brain injury, and I just got out of the hospital and I can't go back to work, I don't have control over very much of my life. But if you ask me, do you want to go in 3 minutes or 5 minutes? Or do you want to wear the red shirt or the purple shirt? Or do you want, you know, this flavor pudding over this flavor yogurt? Give me choice. It gives me some little bit of control over what I still can control in my life. Okay? When we talk about behaviors, the ABCs of behavior, pay attention to what happens before, during, and after. So if someone's acting out and having behaviors, what are the antecedents? What happened before? What's the behavior, and then what's the consequence? What happened after? What purpose does the behavior serve? Do they get a reward when they act this way? And you may not think you're rewarding someone, but if the staff person comes to me and says, okay, Karen, it's time for physical therapy, and Karen hates physical therapy because it's painful and tires me out, and Karen learned that, hey, if I throw things in my room or I yell and scream and cry, then instead of going to physical therapy, this really nice person comes and takes me for a walk and we get outside. The reward might be, hey, I get to hang out with this person and I get outside. So we want to think about what purpose is the behavior serving, or was that an escape? If I act this way and they don't make me do the physical therapy, I escaped a task I don't like. Or is it attention seeking? Do people pay attention to me more when I act this way? So think about these things. We want to praise the positive. We want to ignore negative behavior when able. Next slide, please. Okay. And final slide on it, considerations working with someone. Again, with the attention, concentration, and all these things, gain attention first before making a demand. So before you ask the question or tell them something important, make sure you've got their attention. Back to Karen in the kitchen, make sure Karen's not watching the bird feeder. She's got eyes on you and she's focused before you ask her about lunch. Use a positive, upbeat tone. People are more likely to want to work with you when you're positive and upbeat. I know I'd rather surround myself with positivity than negativity. Limit sarcasm. Again, multisensory approach. And here's the big thing to highlight. A couple big things. And this is the frustrating part for professionals. This is frustrating for family members. What works one day might not work the next. Brain injury is an invisible injury sometimes. It's an invisible disability because we can't see it, right? We can't see it. Someone's thought process is not functioning. And it's inconsistent. How someone presents one day may be different the next. People have their ups, they have their downs, their good days, their bad days. And so you may figure out a schedule and everything's working great, and then a few days later it's not. It's inconsistent because of the fatigue, because of the processing, because of all of these variety of factors that we can't see. So don't get frustrated. Just know that it's common in brain injury that people have inconsistent progress. You know, that 2 steps forward, 1 steps back kind of thing, that's pretty common. A family member that I've known 10 years now has said, it's a roller coaster. You know, sometimes the ride's smooth and everything's good, and then you hit a dip and a turn or a twist, but you just keep going forward. And it's unpredictable. So rather than get frustrated with this, we're just going to acknowledge that, hey, this is brain injury. On the positive side, never a dull moment. No boredom working in this field because it constantly changes and keeps you on your toes. Next slide, please. So we're coming towards the end of the webinar, and I think there is some time for Q&A. But before we get to questions, I just want to emphasize where you can get a hold of the Brain Injury Association of New York State. We have some website tools, Project LearnNet. We have a brain injury training and services program that if you, wherever you are, you want training in your area, we're happy to try and accommodate and do some face-to-face stuff. We have support groups across the state for families and individuals with brain injury. We have a fax program, and there's all of this information is on our website. We have certified brain injury specialist review and exam. We hold them annually before our annual conference, but we also do offer them for small groups across the state. If anyone's interested, you can call us about any of those things. Next slide, please. The resources part. You guys know about the New York Independent Living Centers, right? Great resource, great programs, benefits counseling. There's the New York State Office for the Aging. There's the Department of Health, Consumer Directed, New York Connects. There's a bunch of resources out there. This is my contact information at our main office, and if you have any questions, that's how you can reach me. Next slide, please. And I just want to thank you again for hanging in there with me through this talk. It's really hard to talk to a computer screen, so I hope I came across okay. But and we do have some time for discussion, questions, or whatever else time allows for.
So again, if you use the raise your hand feature, I can unmute, so you'll be able to speak directly, or you can use the type a question into the box field, either one. Karen, that was really informative. While we're waiting for people to ask questions, if they want to ask questions, I'll just say one of the things that struck me while you were talking about is that traumatic brain injury can really be an invisible injury, and the expectations of the public in general might be different. And so when you talk about the allowing time for processing, et cetera, you know, if you're going to a store or wherever and the cashier just keeps asking, well, why aren't you giving me the change? What do you need? You know, that can be a real challenge for individuals just because it's not visible, where they might, that same cashier might very well give extra time to a person with a visible disability to
Right.
change together.
Right. And you know, this is kind of from working in the field. I wouldn't call it a job hazard, but it's on my radar. So when I'm at the supermarket and I see someone get impatient because the line's long, or start stomping their feet, or throw the stuff down and stomp out of the store, you know, you just wonder, like, wonder if there's brain injury there. Or someone with road rage. You know, are you really that upset that traffic's moving slowly, or do you have impulse control issues? Or, you know, sometimes when I see kids, or not kids, like older kids, teens, tantrums and yelling and acting out in public, you just wonder, like, how much brain injury is out there that we don't see. But
So I don't see any questions or any hands popping up. So if there are no other questions, I will just say a final thank you to Karen and to Christine for setting this up. I think this went really well, and it's really good information for all our transition specialists to have, and you know, to help people leave institutional settings. So thanks again, Karen, and you know, your contact information is on here. So if anybody afterwards has any questions, should they just feel free to email you?
Yeah, if I may just say, we're a resource for everyone on the webinar. If you have questions or want more details, our website has information about a variety of things. Our family helpline is there to help individuals with brain injury, family members, as well as professionals. So if any of this is, or if something comes up in the future, just know that we're here. And if I can help in any way, I'm happy to do that.
Thank you very much.
Suzanne?
Yes?
Thanks, everybody.
Yes?
Hi, Suzanne, this is Christine. I just wanted to point something out and have some of the participants think about this. Laura Bingle, the other Transition Center nurse, and myself are doing a webinar on January 19th, Understanding the PRI Screen and the UAS. And I just want you to think about this. Think about what you learned today about people with traumatic brain injuries, and I'm sure most of you are aware that there is some concern over the UAS New York's ability to accurately assess individuals with cognitive impairments, especially within the TBI population. So some of these things that Karen discussed, especially under the strategies section, for example, you'll sometimes see people with TBIs nod and smile when maybe they don't quite understand what you're asking, or they can very easily overestimate their abilities.
Yep.
So I just want to leave you with that thought, because we'll be, you know, that will be part of what we're discussing in next month's webinar, and just wanted to leave you with that. Thanks again, Karen.
Suzanne, if I may ask, are the transition specialists they're not performing the UAS and PRI, they're just being briefed on it?
Yeah, we just felt like it would be helpful for them to have more information on how to read it, how to understand it, what kind of things go into it.
Yeah, and on that note, I just have to throw in my 2 cents that if you know someone having either PRI or UAS, to have an advocate or a family member or someone that knows them present, because just like you were saying, if someone was asked, you know, are you able to feed yourself? Yeah. You know, it's common for people to just give the answer they think you're looking for, and unless you dig a little deeper, ask specifically, well, can you get your groceries? Can you know, feeding myself might mean, yeah, I can microwave these meals, not so much I can prepare a roast chicken. So that's a great topic for you guys to listen to, and yeah, it does have its shortcomings on the cognitive area.
Definitely. All right, well, thank you, everybody, and enjoy the rest of your day.
Thank you.